Hey guys, I'm finally getting down to record this. It's 8 o'clock on Friday night, and generally this takes me a little bit to get out because it takes a while to load. But what I want to do is I just want to go quickly through some of the slides, go through the topics. You'll have to take a little bit more time and understand each one of the topics, but I did want to go through and kind of review the main points. When we get to the disease processes, it's a lot easier if you work to understand what's going on rather than just memorizing. And that'll help you in CHA 1 and CHA 2 as well. Let's get started on this. I'm trying to do this before my family gets back home, but my son's upstairs playing Xbox and occasionally he yells at it. And my dogs are maybe settling down. Let's get this going. Oh, yes, that's them. So, know what leadership is. It's basically a way of behaving, a role that a person prefers to be in, and it really makes others respond or make changes or better themselves, not because they have to, but because they really want to be better, or they really want to perform well. Know the different leadership styles. Contingency leadership. Remember, this is where they're able to adjust to different circumstances. So when you're, the comparison here, when you're taking care of patient A as compared to patient B, you're going to change the way you approach that patient. Maybe patient A is demented, and patient B is, I don't know, looking at maybe a cancer diagnosis. You're going to be a lot different with patient A than you are with patient B. So this contingency leadership, they're going to be a lot different with maybe coworker A and coworker B. Situational leadership is kind of the same thing, but they use different styles of leadership under the situational leadership. Whatever works best to address what's going on at the time is the style that they'll use. Transactional. These guys are more, they envision the future. They see, well, we have this budget and it's been in the red for a year. I want to do this, this, and this to make sure that we are no longer in the red. So they're trying to get others to buy into it. But how they get them to buy into it is more of like a power, a control, an authority. So they'll use incentives. So if you pick up a shift for me, I'll give you an extra $2 an hour. But that doesn't really fix anything. It doesn't fix the staffing shortage. It just covers the problem for right there. Right then and there. Transformational. This is when the leader works with, say, like the DON will work with the nurses, the RNs, the LPNs, the CNAs, the housekeeping, the maintenance, the cooks, different levels to get to a common goal. They're all working together to make change and make things better. Just a summary of it. Communication. Remember that when we're communicating with people, what we say is almost less important than how we say it. Lay down. Sorry, I have a 4-month-old Great Dane puppy and he's crazy. So if you say something, I always like it when people say something really, really nasty and salty and then end it with dear. Just because you put dear on the end of it does not mean that it makes it any nicer. If they're sitting there with their arms crossed, say something salty and finish it off with dear, it doesn't make it nice. So know your communication styles. Passive or an avoidant communication style. These people let other people push them around. They won't ask for help, but if they finish their task, they'll be angry and they will make comments like, yeah, well, they wouldn't help me and they were just taking advantage of me and They never asked if I wanted anybody's help. Aggressive. These are the people that are more dominating. They're angry. They feel like they're superior than other people. And they really don't show any concern for others' feelings. Assertive. These people are the honest, the direct. They'll tell you something tactfully. They'll be respectful. And then they'll take responsibility for their own actions. Conflict. Know the different types. Remember, a Sherman tank is intimidating, overwhelming. They're very confident. They're very demeaning to others. They will come right out and make comments to you. So the best way to deal with them is that if you don't act like you're fearful or angry, and don't confront them. So just talk to them in private and let them vent. A sniper, if you think of them, they're going to get you with a cheap shot. They're not open like a Sherman tank. They're more of like a passive-aggressive, yeah, oh, yeah, that's wonderful. And then the minute you turn around, they're going to be complaining. So always, you can smoke them out and say, hey, yeah, that really sounded like you were trying to be rude. Did you really mean it to be rude? And that's kind of the best way to confront them. Constant complainers. They'll point out problems, but they won't do anything about it. I told my kids that when I was going through this stuff, that they were constant complainers, and they said, yeah, if we complain to you about something, you ask us, what have we done about it? You know, like if they tell me they have a headache, well, did you take ibuprofen? No. Well, then I tell them, don't complain to me about it if you're not going to do anything about it. So just remember, these are the ones that are always complaining, but they don't take any initiative to do anything about it. Clams. These are the people that are difficult to work with. When you need an answer or want to talk to them, they just clam up and they don't answer you. So when we're dealing with these guys, try and leave it open-ended and then wait for the response. If you don't get a response, push them for one. It says wait for them to respond, but don't wait and just not say anything. You can ask them, hey, are you going to return my email? Are you going to return my call? Can you answer this for me? I need to know because I need to get moving on my stuff. Transitioning. If you think of this, if you're working as a CNA, the transition to working as a nurse. Know the different levels. The novice is basically no clinical experience in a nursing student, or even an experienced nurse. Say I'm an experienced nurse on med-surg, but put me in the ER and give me a code, I could be the same thing as a novice. Advanced beginner, this is like your 4th semester nursing student. They start to recognize things if they've been exposed to it before. So maybe like my students the other day, we were recognizing that a lady had an irregular heart rate, and she was sweaty and she was dizzy. So next time that student gets a patient that's showing those symptoms, she may start to look for maybe signs of AFib. So they have to be they have to experience something, and then after they experience it again, and thus recognize it. A competent level is when the nurse has been working on the floor 2 to 3 years after graduation, after passing their boards, so they're competent to be out on their own. Proficient, these nurses are able to recognize and understand the situation. And then an expert, they understand and have knowledge, very in-depth knowledge of the whole entire situation. So as a nursing student, you might know that, hey, I'm giving Lasix because they have edema. But as an expert, you're going to say, I'm giving Lasix because their kidneys aren't working and they're not filtering, and they aren't able to excrete everything because the kidneys don't function as well, and even go further in depth. Reality shock. When somebody has been in school for years, or even 4 semesters, they go through what's called a reality shock. The honeymoon stage is the first stage, and it's like, hey, I'm a nurse, I finally get a paycheck. This job isn't going to be any harder than nursing school. I think you kind of feel this way during like orientation. Shock and rejection. Anytime something doesn't go well, you might blame yourself. This stage, these people are very hypercritical. Why did I go to school? Why did I want to do this? I'm not smart enough. Maybe I should have never gone to school. This stage, I remember this stage. I remember I was off orientation in my first nursing job. I was working PMs at a, 30-bed nursing home. I had finished orientation, and I was, probably my second, third, fourth day on my own. I just stood at the nurses station, looked down both halls, and actually started crying. I'm like, how am I supposed to be in charge of all this? I'm in charge of all their meds, I'm in charge of all the CNAs, I'm in charge of this, I'm in charge of that, and what the heck am I doing this for? And then recovery is more, I can do this, yay, I'm happy I'm a nurse. And then can actually start, making jokes at work and seeing the humor in things, and not just always, my dogs are going to drive me nuts. I have to pause this. Okay, sorry about that, but they've been playing around. And anyways, the recovery phase of reality shock, you're basically happy to be a nurse, and you feel like, hey, I can do this. I'll just learn more every day. Burnout. Know that nursing can cause a burnout. Know the warning signs, and know that need to make sure to take care of yourself as a nurse. All right. Know the difference between a mentor and a preceptor. A mentor just kind of happens. There's no termination date. Somebody actually seeks out the mentor. The mentor shares personal experiences. They demonstrate empathy. They know, hey, I've been there before, and encourages their coworker. A preceptor is somebody who's assigned. It's for a set time limit. There is a termination date. Generally, it's an orientation preceptor, or even in like DEU, you guys, or transition, you guys will have a preceptor, an assigned preceptor. They'll help with all the fine-tuning the skills. And the example here is an experienced nurse and a new grad, or even a nursing student. Scope of practice. This is in chapter N6. Remember that up to 45% of employers actually use social media. So somebody may apply for a job, and the employers look at the Facebook sites, or ChapSnap, or Snapchat, whatever it's called, and really might use that. If you have pictures of you going out drinking every weekend, they may frown upon that. Interviews. Know the different management styles, the autocratic, the democratic, and the laissez-faire. The autocratic is more of an authoritative approach. They really make the decisions for everyone without asking others. It's based on the tasks and not the employees. Democratic is more people-oriented, really tries to get the group working well together. Kind of wants, it's more of like they're sharing power, they're sharing responsibilities. And then laissez-faire, there's just really no direction. Staff members are making and doing changes without any input from the managers. It only works when you have very highly motivated groups, but it's rarely effective. Know these terms: the reward, the expert, the referent, and the leadership. Just the types of power and authority. The reward, they're able to provide or withhold rewards like salaries or bonuses. Expert is a good resource to other people. They have specialized knowledge, specialized skills. Referent is people like their personal characteristics. And leadership, they can create order from chaos or conflict. The change theories, unfreezing. So if a new leader comes in, they're going to look at things that are causing resistance of the employees to make changes. And then they're going to really convince others to work with them. Moving is the part where the group's starting to take responsibilities to start the changes. They're identifying strategies to overcome the resistance or the complacency. And then refreezing is once that plan is in place and it's working, everybody knows about it, what to expect with it. The changes are now incorporated and are sticking into everybody's daily cares or daily routine, and that's refreezing. Remember that 20% of your patients will take 80% of your time. And that's true. Some patients you have will take very little time, but other patients that you have will take most of your time. It could be that they are, high acuity, or maybe they just need help doing this, that, and the other thing. But there will be patients that will take most of your time. So you really need to just, at the beginning of your day, do your priorities, and then at different points during the day, look at your day and reprioritize. So beginning of the day, you need to figure out what your patient needs are. Who's the sickest? Who's the most unstable? Who do I need to see first? Maybe you have a patient that the plan is to discharge home so that they can, get on with, maybe they have a loved one at home that they need to take care of. So plan is to discharge home. You've got a couple other patients. One's in for a possible cancer diagnosis. That was kind of the flavor of the week at clinicals this week. Another one is respite care. So you're going to go in and you're going to see most likely the one that is possibly facing the cancer diagnosis, and then go into the one that is discharging, and then probably the respite care. But if you go into the second patient and the plan is to discharge and all of a sudden they're showing signs and symptoms of AFib, you're going to have to reprioritize your day because that patient that was going to be discharged is now your highest priority. Always use Maslow's hierarchy of needs. ABCs, airway, breathing, circulation, any of those problems are number one. I heard a good one today. It's ABCDEs. And airway, breathing, circulation, drips, drains, and equipment. Those are your priorities when you first walk into a patient room. Know when like the busiest times are. So if you got 8 o'clock meds, you're not planning to do a dressing change during that time. Are each of your patients' 3 Ps met? Pain, position, and potty. If those 3 Ps are met for each of your patients, it will make your day go a lot smoother. And then learn to delegate. We can delegate appropriate tasks. So if maybe our patient needs a HIPAA-cleansed bath before surgery, we don't have to do that if we're nurses, if we're busy with something else. We can always help, and I always encourage people to help their CNAs. But if we got 16 other things going on, like our second patient that went into AFib, we need to take care of that patient, and we can have our CNA do the HIPAA-cleansed bath for the patient that's going to surgery. We're still responsible for what we delegate, but we can have someone else do it. Another example is if you're working in the nursing home and one of your patient's residents needs like TED hose put on. Your CNA will put them on when they're getting them up and ready for the day, but you will still sign it out. I cannot stress enough to use a timeline or a brain sheet or something that has each one of your patients on it so that you have all the information in one place. Know the different torts. An intentional tort is a wrong committed by one person against another person deliberately. An unintentional is a wrong committed by one person against another person, I guess, or property that is not meant to, it was not done on purpose. An accident. The most common unintentional tort is a malpractice claim. I can give you the example of a gait belt. When I first started practicing, I was like, yeah, I would see people transferring without a gait belt, and they'd be like, you really should use a gait belt. But now, the more I've learned and the more knowledge I've gotten, if I see somebody transferring somebody without a gait belt, it almost scares the hell out of me. Because if you transfer a person without a gait belt, and it is in their care plan that they transfer with a gait belt and a walker, and that person falls and gets hurt, that is an unintentional tort. So this person, you did not mean to make them fall by any means, but had they have had their gait belt on, like you were supposed to have, they may have not gotten a fractured hip. So a malpractice suit has to have four pieces. A duty, so they have to show that there was a duty for the nurse to be taking care of the patient. There has to be some sort of connection. If you are, maybe you're not a nurse, but you drive by and you stop in an accident, there is no, they can't prove that there was a duty for you to take care of that person. But if you are working in a hospital or a nursing home or anywhere where you're dealing with your patient, you are responsible for that patient. It is your duty to do the best you can to take care of that patient in the moment. A breach is any time that the care falls below the standard. So anything that you were taught in school, there's a standard line. Anytime that your care, I gotta stop this again. Yeah. Leo? Okay, sorry about that. And plus we have wood floors, so you can hear every step that my dogs take. Plus my puppy is 60 pounds, so he walks like a cow. Alright, so a breach is anything that falls below that standard of care. What would a person with the same amount of training do in the same situation? A breach foreseeable is what the likely thing that caused the injury. Maybe it was a med error, or maybe it was the gait belt, not wearing the gait belt. And then damages or injury, they must be able to prove that there are damages or there is an injury that occurred because you did not put a gait belt on that person, or because you gave them too much, I don't know, Lasix, whatever. But they have to be able to prove that there was a damage to them or an injury. Avoiding a malpractice claim, always accept accountability. If you have a med error, please report it. They are non-punitive anymore, but admit mistakes. Sorry, my dog's eating something. I'm going to do this after everybody goes to bed with the other two. Always communicate and always chart like you're going to take whatever you are in if you're going to read it in court in 5 years. Intentional torts, this is like assault and battery, false imprisonment. You know, if you don't stay in your bed, I'm going to sedate you, or I'm going to tie the call light to the ceiling so you can't reach it. And then defamation, which is libel and slander. So it would be where you would cause damage to someone's reputation, or you're going to talk negatively about them. Maybe you got into an argument with a doctor. Going out and spreading how stupid he is actually defamation. I can't say it. Defamation. And other intentional torts include breaking HIPAA. So if you are talking to someone, always ask yourself, do I have the patient's consent to share information about them? So if, say you guys are doing your rotation in mental health, somebody calls and says, hey, I'm looking for my daughter, so-and-so, is she there? Well, if they have not signed a release, you can't even say that they're there. Or maybe they are there, but they did not sign a release for you to talk to anyone, and it's mom, and she's wondering how her 21-year-old daughter is there on a detox hold. You can't tell that mom anything unless that patient has signed a consent that you can talk to the mom. So that's pretty much the stuff from week 1 that I want you to go over. And like I said, try and have an understanding of it rather than just memorizing information. It'll help you out in the long run, and it'll help you on the test. I'm going to take this and load it now. It will take me probably it takes probably about 45 minutes for this to load. But I'll get it posted as soon as possible. And then once my kids have gone to bed and my dogs have gone to bed, I will get the other 2 out yet tonight. Yeah, I was checking the weather. All right, have a good one, guys.